Mature lymphoid neoplasms. So mature lymphoid neoplasms, these represent a diverse group of disease entities with varying clinical presentations and different natural histories. Disease states can be related to a normal cellular counterpart found in either peripheral blood, bone marrow, or lymph nodes. Classification is going to be based on the primary site of the disease. So we have lymphoproliferative disorders. This is a broad category that encompasses abnormal proliferation of mature lymphoid cells. Leukemias, which are primarily involved with the blood and bone marrow. These are characterized by increased mature or immature lymphoid cells circulating in the blood. Lymphomas are diseases primarily localized to lymph nodes in spleen. These present as solid tumors of the lymphoid tissue, and they may involve extranodal sites like the GI tract or skin. For immunologic diversity, so we have the role of the chromosomal translocations. So chromosomal translocations cause genes to be misplaced within the genome. These result in altered expression patterns of important genes that regulate cell growth, survival, and differentiation. These changes are key drivers in the development of many lymphoid neoplasms. So from examples, we have MYC, which is normally stimulates cells to enter the cell cycle. When dysregulated, it actually drives uncontrolled cell proliferation. For BCL2, it functions to suppress apoptosis, which is that programmed cell death. Overexpression can lead to increased cell survival by preventing normal cell death. BCL6 acts as by suppressing transcription of genes that regulate cell growth. Its alteration disrupts normal control of cell growth and differentiation. So these genetic changes contribute to abnormal proliferation and survival of lymphocytes, promoting lymphoid malignancies. For classification of lymphoid neoplasms, we look at morphology, genetics, BT and NK autogeny, and the WHO classification. For morphology, this is the first step in diagnosis and evaluation of those lymphoid neoplasms, but there are a lot of diseases that have overlapping or similar morphological features, which makes the diagnosis from this very challenging. Genetics, so understanding the autogeny of B cells, T cells, and NK cells is essential. Genetic features can help to clarify the biologic behavior of the neoplasm. And genetic abnormalities provide important insights into prognosis and actually for treatment response as well. Genetics and immunophenotyping form the foundation for modern classification systems such as the WHO. So the WHO classification actually integrates morphology, genetics, immunophenotype, and clinical features for a more comprehensive approach for differentiating this. So signs and symptoms, clinical presentation can vary widely from asymptomatic being caught kind of on accident to severe and sudden onset of symptoms. Some common symptoms include fatigue, fever, night sweats, and even weight loss. As far as laboratory testing goes, we look at certain testing, so CBC or a complete blood count. It may be normal or it may show some abnormalities. We can also do a manual differential, and that's often necessary to identify the abnormal cells. For flow cytometry, we can use that to characterize cell surface markers, which will help aid in diagnosis and classification. We can use fluorescence in situ hybridization or FISH, which can detect specific chromosomal abnormalities and translocations. And then there's also anatomic pathology testing that can be done, such as a biopsy. So they would use a excisional biopsy of a lymph node or involved tissue preferred for definitive diagnosis. They can also do a fine needle aspiration, which is less invasive, and it's useful in some cases, but it's not always completely sufficient for full classification. For prognostic evaluation, it will incorporate clinical, laboratory, and pathologic data, and this will help guide treatment decisions and estimate outcomes. So the first one we'll talk about is chronic lymphocytic leukemia, or CLL. This is the most common leukemia in adults in the Western countries. It represents about 1.1% of all new cancer diagnoses per year. It predominantly affects older adults. Typically, these are diagnosed in patients over 60 years of age. So CLL is a malignant disorder of mature B lymphocytes. It is often asymptomatic at diagnosis, and it's usually just discovered incidentally during routine blood draws. So the peripheral blood smear typically will show a smudged lymphocyte, which are fragile lymphocytes broken during the slide preparation. For morphology, the peripheral blood will contain more than 85% lymphocytes, which are small, mature-looking lymphocytes. The nuclear chromatin has a distinctive cobblestone or clumped appearance. The bone marrow and lymph nodes often show infiltration by similar mature lymphocytes as well. For immunophenotyping, the CLL cells express typical B cell surface markers, including the CD19, CD20, and CD23. So a hallmark of this is the apparent expression of the CD5, which is a T cell associated antigen, which is uncommon on normal B cells, but it is consistently present on the chronic lymphocytic leukemia cells. So this unique immunophenotype helps distinguish CLL from other B cell lymphoproliferative disorders. For staging and prognosis, so there's two main clinical staging systems that are used to evaluate disease and guide the treatment. We have the Ray and the Binet systems. So staging is based on physical findings, blood counts, and marrow involvement. Early stages may require only observation, so kind of watch and wait type stuff, while advanced stages with cytopenias or symptoms generally will start to need treatment right away. Prognosis will vary widely, with some patients living many years without progression and others experiencing aggressive disease. For treatment, this is reserved for symptomatic or progressive disease patients. Recent advances have shifted therapy towards targeted agents that actually disrupt key pathways in the chronic lymphocytic leukemia cell survival and proliferation. This helps to improve outcomes with less toxicity compared to traditional chemotherapies. So they have common targeted therapies, and this includes Bruton tyrosine kinase inhibitors, which can block the B cell receptor signaling. We also have phosphoinositide 3 kinase inhibitor, which interfere with survival pathways. And we have the BCL2 inhibitor, which promotes apoptosis of the CLL cells. So these agents are often used alone or in combination, depending on patient and disease characteristics. Then we move on to prolymphocytic leukemia. This is a rare lymphoid leukemia that accounts for about 1 to 2% of all lymphoid leukemias. This typically occurs in older adults with the median age being around 70. For clinical features, patients often present with marked lymphocytosis, which is a very high white blood cell count or very high lymphocyte count that can rise rapidly. They'll have significant splenomegaly. Symptoms may also include fatigue, night sweats, weight loss, and other systemic features that can reflect, the disease and that it's being aggressive. Morphology, they can have peripheral blood that's going to show medium to large lymphocytes with more open chromatin compared to your typical small lymphocytes. The nucleus is prominent, often with a visible nucleolus. You'll also have presence of prolymphocytes, which are the immature lymphoid cells. They'll have more cytoplasm and a prominent nucleoli. And this is kind of a diagnostic feature of the prolymphocytic leukemia. So finding a significant number of prolymphocytes can distinguish prolymphocytic leukemia from other lymphoid leukemias and lymphomas. For treatment, they're kind of limited and generally less effective compared to other lymphoid leukemias. This disease is unfortunately often aggressive and resistant to standard therapies. So clinical management will focus on supportive care and sometimes use of chemotherapy or targeted agents, though responses are variable and typically not great. Hairy cell leukemia, morphology for these cells have a round or oval nucleus. They typically lack a nucleoli, and it's characterized by hairy or ragged cytoplasmic projections. So that first top picture on the right is actually what it looks like. So you see the fine, irregular cytoplasmic extensions on peripheral blood, and you'll actually sometimes see it on bone marrow aspirates as well. For treatment, you can use nucleoside analogs, and they target the DNA synthesis in the malignant cells. And these agents will often induce durable remissions and are highly effective in hairy cell leukemia. Hairy cells may be difficult to locate in the bone marrow aspirate because this disorder is often accompanied by a fibrosis, which can make obtaining that adequate smear problematic. So the leukemia cells have a characteristic appearance with a shaggy cytoplasmic border. For that T cell large granular lymphocytic leukemia, the morphology is characterized by large lymphocytes with abundant cytoplasm. The cytoplasm is pale blue and contains medium to large eosinophilic granules. These typically constitute about 15% of circulating lymphocytes in affected patients. For the treatment, it's often managed with immunosuppressive agents due to an autoimmune component of the disease, and commonly used drugs include the low-dose methotrexate, cyclosporine, or cyclophosphamide. For lymphomas, we have adult T-cell leukemia or lymphoma. Incidence, it occurs in about 2.5 to 5% of individuals that are infected with human T-cell leukemia virus type 1. This infection is endemic in certain regions such as southwestern Japan, the Caribbean, and parts of Africa and South America. For morphology, patients often present with leukocytosis. They'll have a characteristic flower cell seen in the peripheral blood smear, so atypical T cells with multilobulated or convoluted nuclei resembling flower petals. That's that top one on the right. Kind of looks like a flower if you look at the nucleus. Treatment is primarily treated with chemotherapy. And in elegant patients, sometimes they can do stem cell transplantation if needed. Prognosis is generally poor and treatment can be challenging. Then we move on to Burkitt lymphoma. This is common in children, especially in Africa. Also occurs sporadically worldwide, including in adults. Morphology, so cells are medium to large sized lymphocytes. Nuclear chromatin is finely clumped. Cytoplasm is deeply basophilic and contains vacuoles. For treatment, it is treated aggressively with chemotherapy, which can lead to high cure rates if initiated promptly. Treatment protocols often include intensive multi-agent chemotherapies. Follicular lymphoma, for the morphology on this, you have neoplastic cells have condensed chromatin with characteristic nuclear clefts, which are like little indentation or groove in the nucleolus. Typically, it's going to show a follicular or nodule growth pattern in the lymph nodes. Treatment may be deferred as asymptomatic, kind of like a watch and wait type thing. When needed, treatment can involve chemotherapy and can sometimes be combined with monoclonal antibodies as well. Mantle cell lymphoma, so the morphology on this, it's going to vary by subtype. So small cell variant is going to resemble chronic lymphocytic leukemia cells with small mature lymphocytes. Blastoid variant, these cells are going to be pleomorphic and immature, which will show a high-grade feature and aggressive behavior. Treatment for this is chemoimmunotherapy, which is a combination of chemotherapy and monoclonal antibodies. Autologous stem cell transplant could also be used, especially in younger or fit patients, and that will help to prolong remission. And then we have diffuse large B-cell lymphoma. The morphology on this is it's characterized by large lymphoid cells with a diffuse growth pattern, replacing the normal lymph node architecture. Cells have a large nucleus and prominent nucleoli. Standard treatment for this is immunochemotherapy. And as mentioned before, that is a combination of monoclonal antibodies and chemotherapy. Marginal zone lymphoma. So this is usually associated with chronic antigen stimulation, such as infections or autoimmune conditions. For morphology, in the peripheral blood, we may see lymphocytosis with lymphocytes that have villus projections, like hair-like cytoplasmic extensions. These villus lymphocytes are characterized, but they're not exclusive to marginal zone lymphoma. Mycosis fungoides, or Sézary syndrome. This is a disorder of the CD4 T helper cells. So we have malignant cells that have scant cytoplasm, folded or cerebriform nuclei, and condensed chromatin. Sézary syndrome is a leukemic variant with circulating malignant T cells. For treatment, it's an early stage disease. It may respond to steroids and phototherapy. In the advanced stages, it's generally incurable and may require more aggressive therapies. For anaplastic large cell lymphoma, for the morphology, tumor cells are going to vary in size but typically show large cells with irregular nucleoli. Cells may have a horseshoe-shaped nucleus, and that's kind of the hallmark for this disease. For treatment, you're going to primarily treat with chemotherapy. You could also potentially use targeted therapies in certain cases depending on molecular markers. For plasma cell neoplasms, these occur when abnormal plasma cells form cancerous tumors in bone or soft tissues. When there is only one tumor, the disease is called a plasmacytoma. When there are multiple tumors, it is called a multiple myeloma. So multiple or plasma cell myeloma is a bone marrow-based malignancy of plasma cells that can extend into bone and soft tissues. It is characterized by proliferation of malignant plasma cells producing monoclonal immunoglobulins. For the morphology, you'll see an increased plasma cell observed in the bone marrow, and it will often exceed 10 to 20% of the marrow cellularity. Presence of a rouleau formation in peripheral blood smear where red blood cells stack like coins is due to increased paraproteins. So associated with secretion of the paraprotein is detectable in serum or urine as well. Waldenstrom's macroglobulinemia, so morphology. This is a lymphoplasmacytic lymphoma, and it's characterized by a secretion of IgM monoclonal protein. These cells often have features intermediate between lymphocytes and plasma cells. The molecular marker for this, so if there's a presence of mutations in the MYD88 gene, it's useful for diagnosis and prognosis. Hodgkin lymphoma, it's a lymphoma primarily involving the lymph nodes. Its incidence is about 2.7 cases per 100,000 people per year. For morphology, it's going to be characterized by the Reed-Sternberg cells, which are large, bi- or multinucleated cells. These cells have abundant cytoplasm and distinctive nucleoli, often described as owl's eye appearance. The Reed-Sternberg cells are pathogenomic for Hodgkin lymphoma and are surrounded by a reactive background of non-neoplastic inflammatory cells.